Our final subject for this issue of ACCEL features a discussion Al Waldo had with Dr. Sripal Bangalore, Assistant Professor of Medicine and Director of the Cardiovascular Outcomes Group at the New York University Medical Center in New York City, to discuss what a clinical cardiologist needs to know to correctly interpret statistical data in meta-analyses.
Welcome.
Thank you.
So, Dr. Bangalore, why don't you start with telling us what a meta-analysis is and what it should consist of?
So that's a great question. I think the bigger question is, why should we even think about this? Why should we waste time on trying to understand a meta-analysis and interpretation? I would say one of the major reasons is the number of publications in terms of meta-analysis in the last decade. And there has been a tenfold increase in the number of meta-analyses published since 2001. And just last year, this is a quick search. If you look at PubMed, there have been 14,000 meta-analyses published. So it's more likely that a clinician is going to come across a meta-analysis in the next month or so. It's going to be in every journal. In terms of what constitutes and what are the factors a clinician should be looking for, I would say the search is the most important thing. How did the authors do systematic search of the literature? And the reason that is important is we need to understand if there are any publication bias in the included analysis. Of course, it's easier if you look at the published results section of the meta-analysis. There are various ways to look at if there is publication bias, and one of them is the funnel plot, which is usually published, and we're looking for symmetry of the funnel plot, etc. And there are statistical numbers we can look to see if there is a significant publication bias. But in general, even if those numbers doesn't hint towards high publication bias, there could be publication bias of a different kind. We know that there could be a file drawer effect. A file drawer effect pretty much means that it's more easy to publish positive trials than it's easy to publish a negative trial. In other words, most of the negative trials would sit in the file drawer of the investigator.
Unpublished.
So what that would mean is if the investigator actually did a search of only published trials, they're only going to find positive results. So their treatment effect, they would conclude by saying it's positive, whereas there would be a wealth of information in the file drawer of the investigator pointing to the opposite effect. That is, there is no difference between the treatment effect.
So how do you find this out if you're the reader?
That's a great question. So how do you actually know that there is a lot more negative trials out there? And one of the ways you can know is making sure that investigator has not only included published full text journal, but also have they gone through abstracts. It's possible that a negative results presented as an abstract, a major conference, might take longer for them to actually get it published. So if there are such abstracts, I think it's reasonable for the investigator to actually reach out to those authors and say, do you have data? And
so it takes some work.
It takes a lot of work.
But an abstract is minimally peer-reviewed.
Right. So there are pluses and minuses. So abstract, as you correctly point out, it's minimally peer-reviewed, and many a times it might not reach a publication level just because there are flaws in the methodology which a peer reviewer caught. So there are positive and negative aspects of including the abstract, but at least you know that there are a few other trials which might be negative out there. And one of the things which we have commonly used is actually looking at the FDA website. So FDA website generally includes drug approval process, and there might be more data in those FDA dockets than which is published in the public domain.
So let's think of some concrete examples. One interesting area that's gotten a lot of attention with statins, the statins and diabetes. Is that a good thing to think through with you and how you decide what the meta-analysis is saying and what's good and bad and indifferent or whatever?
That's a prime example in terms of statins and the risk of future cardiovascular events. And we know that it's extremely difficult nowadays to design large trials aimed at single endpoints. For example, if you want to look at all-cause mortality for a primary prevention subgroup with statins, it's going to take tens of thousands of patients. So many a times it's not possible to just design a randomized trial, and you might resort to doing a meta-analysis of published data. In terms of that, I think the purest way and the best evidence for a meta-analysis is individual patient-level data meta-analysis. So this has been done, and the Cholesterol Treatment Trialists Collaboration has published in the last few years a couple of articles where they pool individual trial data from all of the statin trials, that has a higher level of evidence than pooling individual trial data. And I think there was a publication recently in The Lancet looking at statins based on patients' baseline risk factors. And it's an interesting meta-analysis in that they showed that in terms of vascular event reduction, there was a significant effect of statin even in those where the baseline risk was less than 5%. I mean, this is a population which I think you and I would never consider prescribing statin to. So if your Framingham risk score was less than 5, there was still benefit of adding statin to those cohorts.
Yes. So are the diabetes data then worrisome in the statin literature?
It's been consistently shown, I mean, both from individual patient level data and from trial level meta-analysis that statins increase the risk of diabetes. I mean, it's usually a small 8% increase in the risk of diabetes. But what's been important has been that in all of these analyses, even with the 8% increase in diabetes, there has been a risk reduction in all-cause death or vascular events.
Very important. Now, another thing that might be important, and maybe using the same analysis, maybe the statin data with diabetes identified a population that was prone to diabetes without the statins. Right. I mean, if the maybe metabolic syndrome kind of patient. I mean, I think some of the data showed that obesity was part of it. Would you discuss that aspect of things?
So that's a great question in terms of confounders. So yes. Is it that the patients who are more likely to develop diabetes would have developed this anyway without the interference with statins? I would say that in most of the trials, we've seen it even in single randomized trials, that there is a trend towards increased risk of new onset diabetes. So if you assume that the baseline risk factors were similar between the statin and placebo, you should see the same effect in the other group. So I would say based on what we've seen, we cannot completely rule out that statin per se would increase your risk of diabetes.
And isn't that the answer? It's placebo-controlled, the importance of placebo-controlled.
Right. So it just highlights the importance of placebo-controlled trials. Again, at the end of the day, it's risk-benefit, and yes. The risk-benefit ratio clearly favors use of statin.
What are some other points you might wish to make about meta-analyses and how the clinicians should think about them?
So I would say that in addition to the search, the other important aspect for a clinical cardiologist is to see what exactly was done in terms of the analysis and what was the interpretation. There is a tendency to over-interpret meta-analyses. And many a times you have to make sure that it's actually supported by the analysis.
One other example about ARBs in cancer, how the meta-analysis performed. Could you just comment on that?
So there was an analysis which was published in 2010 in the Lancet Oncology, where they analyzed 5 trials and found that there was an 8% increase in risk of cancer with the ARBs. And we did a similar analysis, published in the same journal 6 months later, and found that there was no increase in the risk of cancer with the ARBs. And of course, subsequently, both the FDA and EMA did their own separate analysis and kind of agreed with our findings that there is no increased risk. So this analysis, actually, just to quickly say what were the differences, the first analysis had only 8 trials, and our analysis had 21 trials between ARBs and controls. It just goes to highlight the fact that there are a lot more trials out there. I mean, it needs a thorough search. And secondly, contacting authors for unpublished data is definitely helpful because the results dramatically changed by addition of newer data from unpublished trials, from being positive, looking bad for ARBs, to a neutral effect.
Maybe I'll ask you just for a summary remark. So what should the reader think about meta-analyses? They're very important, obviously. They have to understand limitations, and they have to understand some of the technicalities of what was performed.
So in terms of the statistical technicality, that's one good part of a meta-analysis. I don't think the clinician should be too much concerned because it's pretty standard. What the reader should read is how the search was performed. And in their mind, can they think of studies which might have been excluded? Or were there limitations imposed based on language or some other criteria which might make it not so generalizable?
Well, thank you very much. I think meta-analyses are clearly here to stay.
Thank you.
And that concludes this edition of ACCEL for December 2012. For details about studies discussed on ACCEL, refer to the written summary included as a PDF file on this disc. This issue of ACCEL qualifies for up to 4 Category 1 CME credits. To To obtain CME credit, go to www.audiodigest.org/online testing. This is Alfred Beauvais for the American College of Cardiology. Thanks for listening.